So Robert Smith, the audience will well know, was a Victorian surgeon working in Dublin, whose career overlapped with that of his mentor, the more associated with the Georgian era, Abraham Collis. The two were co-founded the Dublin Pathological Society, and there's such a rapport, although at different ends of their career, that Collis asked him to perform his post-mortem examination, as he thought this would be important for society to know why he died. In return, as a Dubliner, Smith paid Collis the ultimate compliment of not actually trying to just undermine his reputation until after he died. And in the same chapter as when he described Smith's fracture, you can see that he was already changing the eponymous fracture associated with Collis. Both these men were working way in advance of plain radiology. Collis's description was over 80 years before these were available in the clinical setting, more than 20 years after Smith's death. But both of them, I'm sure, are very pleased at how this innovation, this technological innovation, has been exploited now for great success. And indeed, over the last 100 years, that we've seen dramatic changes in the operating theatre, but more especially in surgical technique and technology. And the most compelling thing about this, I think, this picture of a single-port laparoscopic total colectomy, is that this operation has been done without any scalpels, scissors, or sutures, which would have been impossible to imagine back in Smith's and Collis's days. The procedure of a single-port total colectomy is mostly taking advantage of the improved laparoscopic view. So while in the US this is called minimal access surgery, I think it's really important that we continue to view it as laparoscopy. It's the view is really what's allowing us to operate in a different fashion and better than ever before. And as a benign disease, we know that we can change operative extent based on the disease. So in order to do these kind of surgeries to a 3 centimeter incision, we're leaving behind the mesocolon. We're using energy devices to ensure that we get excellent hemostasis throughout. And the whole operation can be done now in about two and a half hours, even in the sickest of patients. The single port has been held up, though, by the commercial devices, which all have a very cylindrical construct, and of course they're expensive. And in fact, the simplest types of innovations are often the easiest, and the glove port is a very straightforward way in order to adapt to a standard wound protector in order to perform multi-instrument working. And although it's cheap, its main advantage is actually it's better than the current commercial devices. The thin elastic membrane stretches and allows rotation, and you get a markedly enhanced degree of instrument tip abduction and adduction. You can move in and out of the patient as you're operating in free space, and you have a great degree of rotational freedom. It is also cheap, so it's quite common to beat up on single port laparoscopy as being expensive with devices, but this type of a glove port is actually cheaper than its multi-port equivalent, predominantly because you're not using any obturators within the trocars. And by using this kind of glove technique, it means we've been able to expand our practice. In fact, it leads to a very simplified setup, so we're using very few instruments. Single port surgery requires 2 surgeons only, but it means you can move easily between theatres or even hospitals, depending on what the equipment is available. There's no need to pre-order it. You don't need to select the patients in advance, because there's no real financial or even time penalty if you need to convert to multi-port laparoscopy. And we feel that probably this kind of reduced access operating is probably of most use in perhaps the sicker patient, the ones who we know have poor wound healing. And again, the acute severe colitic is quite a good, I think, cohort for this. And that these are sick patients, both because of their failed immunosuppression and because, of course, of the severity of their disease. And over the past 32 months, we've been performing this really on a consecutive basis. There was 2 exceptional cases who had a multi-port laparoscopic operation, but otherwise we're starting on all comers. And added to 27, we've needed to add ports in only an additional 5. What the advantages of this we've been looking at in comparison with the more standard multi-port technique. And you can see that we're doing these in actually a quicker operative time, probably because we don't have the setup time or indeed the wound closure times at the end of it. But it is interesting, although we're doing the single port significantly quicker than the multi-ports, we're failing really to turn this into an improved turnover in operative time. Coming back, I think, to the point the previous lecturers would make, that this really needs systems and organizational effort in order to maximise a change in technique or technology. Compellingly, though, the patients do go home faster than the multi-port equivalent, a medium of 2 days, perhaps because the stoma seems to work a little bit faster, but perhaps that these patients who are vulnerable and concerned maybe are able to engage a little bit faster with their stoma because they're not concerned about the additional effects of stoma leakage onto the wounds. And when we do case-match pairs, we find that these advantages are confirmed, and the complications are that expected of the disease severity, while post-operative CRP is reflected with the fact that it's been a colectomy. But importantly, patients seem to like the added effort that this type of approach adds, and perhaps that translates also into their improved length of stay. So not only is it the colytic patients, but also the young cohort of patients with Crohn's disease also fit well into this group. So what you're doing is you can hide the incision in the umbilicus, and I think it's important that surgery for the Crohn's patient has been portrayed all through from their diagnosis onwards as a failure of treatment. And indeed, one of the endpoints we're seeing increasingly in the medical literature is avoidance of surgery. So I think it's important that we can assure them that there is likely to be small scars. Of course, it is safe. Equally, it's a single focus of abdominal wall probably permits reoperation at an easier extent. It confines the extent of adhesions, and you can place regional anaesthesia into the wound, ensuring that they have sufficient analgesia for the first 30 hours after the operation. But more and more as we're using single port for the sicker patients, in fact, we're starting to view it as a very safe means of entering into the hostile abdomen, or indeed in the hostile circumstance. In effect, this is a mini laparotomy, and perhaps it is the 3 centimetre incision that you're making is a safer means of accessing the difficult abdomen than just doing a stab incision blind. And we're using it for a variety of emergency settings. And in fact, skipping even the stage of multi-port laparoscopy in needs of conversion, as it allows you to escalate straight to midline laparotomy once you prove the disease, and sometimes even the salvageability of the patient. Now, of course, this audience will be familiar with transanal endoscopic operating, again using a long cylindrical rectoscope in order to access diseases of the low and mid rectum. But the single port devices, again, probably perform better, at least ergonomically, than the standard and quite expensive transanal endoscopic gear. They do lack a little bit of the stability that's associated with being able to tie these devices onto the table, but no doubt that's going to evolve with time. Because in addition to having the greater capacity of instrument movement, which helps certainly at suturing the excision sites, the inflation of the glove, or indeed the applied medical device, means that your fulcrum point is backset away from the patient, and you have greater ability to operate within the rectum. And what we're seeing now is a realization that, in fact, these type of approaches and technologies might be a better way to access the mesorectum, which can be a difficult part of an operation, whether the top part is done open or indeed laparoscopically. The narrow male pelvis can be a difficult challenge, no matter how the operation has been done from above. And it might make sense to address the low rectum horizontally, perhaps even with 2 team working. And you can see particularly on the right-hand side, I think this is a video from Roll Thompson in Oxford, that we're seeing very beautifully now the anterior part of the low rectum, and in fact appreciating, I think, Denonvillier's fascia better than we ever have before. When it comes to cancer, though, of course, we still have to do the same radical extent of the operation. And although we can have a 2 or 3 centimetre incision to perform your right hemicolectomy or anterior resections, we still very much have to respect the fact that we need regional clearance, because we still don't know what the stage of the lymph nodes are, despite improvements in CT and MRI scanning. But here too, there probably is a role for laparoscopy, and particularly if we move beyond just the white light electromagnetic spectrum. If we start to move up into near infrared energy capacity, we're starting to have an energy that will penetrate into tissues quite safely and quite different to the ultraviolet range of the energy spectrum. And certainly there's a variety of commercially available laparoscopes that have this capacity both to irradiate in the near infrared range and then back filter out additional returning light in order to make sure you just get this penetrative view. So I'm going to explain what that means with some video illustrations. But there's no natural fluorescence in the near infrared range, so all this technology requires an injection of an agent in order to shine it up inside the patient's tissues. And ICG has been around for a long time as a lymphatic mapping agent. It's very safe, it's very cheap, and it's a very small molecular size dye. So what we've been doing is injecting at the time of definitive surgery on-table laparoscopy for early stage colon and rectal cancers. So this is at laparoscopy. We're doing a flexible scope to the point of the tumour. We're injecting this low molecular size dye just into the submucosa. We're watching carefully on the outside in order to make sure that there's no dye spillage, because that will cause a very intensive fluorescence around the peritoneal cavity. So this is much like an endoscopic ink tattoo. And in fact, ICG has been used for a long time as an endoscopic ink tattoo and probably will persist in the tissues for at least 7 to 10 days after its injection. Within a few seconds, within about 45 seconds, this dye will diffuse simply into the lymphatic systems that's supplying that region. So although this isn't cancer specific, it is specific to the lymphatic system. So the laparoscope, by switch activation, you can flood the visual field with near infrared light, and then you'll see that we're going to pull a back filter across the camera in order to exclude the other light signals. And you see here at the base of the inferior mesenteric artery, these are nodes definitely within the draining distribution of the distal sigmoid cancer. This patient's BMI, I think, was about 28. And interestingly, as we look on up beside the aorta, we're starting to see higher level nodes which are draining within the lymphatic chain, but wouldn't normally be within the standard resection field of the operation. Now, once you see these nodes, and we're just identifying nodes or road mapping them within the distribution, of course it's compelling to try and decide, are they cancer-containing nodes? Because here we might have the first real-time ability to really tailor operative extent. So one of the most obvious candidates would be to use laparoscopic ultrasound. But the problem is that these nodes are about half a millimetre in size or even less, and they're probably beneath the discrimination ability even of directly placed laparoscopic ultrasound onto them. So though you can see the cortex, you can make some opinion about the size or character, it lacks the discriminative ability to go closer down to it. But again, light technologies are evolving. Optical coherence tomography is used in gastroenterology and cardiology, and again as a fibre-based probe that you can place directly onto the outside of the bowel wall, perhaps to T-stage, but also directly onto the nodal capsule. You can see on the lower pictures that they're starting to look familiar in comparison to standard pathology, but again probably lacking discrimination, except for the cortex, which is where about 95% of lymph node metastases are going to lie in early stage colon cancer. So the use of this is probably twofold. Well, threefold if you allow the simplest means of road mapping a flexural cancer, which we still really probably aren't sure whether we should do an extended right hemicolectomy or indeed an extended left hemicolectomy on. But this simply could indicate the lymph node pattern of the tumour and allow us to be more intelligent in the operation. But for the polyp cancer, this is this 1 centimetre polyp that came back surprisingly as a cancer. And we know that in a T1 cancer, at least 90% of these will have no lymph node metastasis, and therefore the polypectomy had been curative. but an ability perhaps to go back in within that 7 to 10 day window of the endoscopic injection capacity and maybe focus our intent on the most important nodes for that distribution could perhaps maybe allow us to a greater degree of confidence in endoscopic treatment of early stage colon cancer. The other way this could go, though, is to allow us to do bigger operations with again, better intelligence of who's going to benefit from it. And you see this mid-rectal cancer and the ink tattoo. You'll see in this case we're shining up nodes in the lateral side wall. So these are nodes along the internal iliac artery, which we don't, at least in the West, currently take out routinely. So what we've been doing with these cases is a standard radical resection, but then we berry pick out these nodes for additional staging capacity. As I said, you can give the dye before the operation. Here's a case of a cecal cancer who had the dye given by colonoscopy 24 hours before the operation. But the small molecular size of the dye means that it just leaches through the lymphatic basin. But if you look here at the black and white view, you'll see that you're going to see at least maybe 14 or 15 different nodes, which is what the pathologist's recommendations are to ensure a standard clearance. The technology will move on, of course, and it's possible simply just to now false color the image, so there's no need for switch activation. And you can see this intensely shining green light. But most compellingly, we probably can also use light technologies in order to exploit differences between tumor cells and the background tissue. So this is a video from David Jane's group in Leeds as part of the LISTEN trial, which is using protoporphyrin differences in order to show up red tumor cells in a patient having their operation. The problem, though, we still have, though, in colorectal surgery is really anastomotic leak, which remains a complete catastrophe for the patient and the healthcare provider, but also, of course, undermines completely what it is we've been trying to do. And we still don't really have a method to prove the viability of a colorectal anastomosis in situ. Sure, we blow some air into it and try and see is the jacuzzi test positive by bubbling. But other than just assessing its mechanical integrity, we basically just wait and see what happens to the patient over 4 or 5 days afterwards. And something like ICG can also be injected directly via peripheral cannula and be a means to perform a perfusion angiogram. So at least we know at the time of its construction that we have indeed ensured a very good blood supply to the colorectal anastomosis. So these steps will be familiar to the audience, but once the anastomosis is made, we now can put in the laparoscope. Within a minute of the ICG circulation via the peripheral cannula, you start to see now nice reassuring blood supply down on the colonic side towards the anastomosis. You can check the rectal sump side by placing this in endoscopically transanally. And aside from documentation of a correctly done operation, there is potential here for allowing us maybe to avoid a stoma in the case in the mid or low rectal anastomosis, which has otherwise gone well, perhaps in the patient who hasn't had neoadjuvant therapy. But again, I suppose the criticism at this point is that this really is still a subjective test, and perhaps it's not much different in just looking at the blood supply at the cut end of the bowel once it's extracted by means of a time of anvil placement. But certainly this is just a matter of software mapping, and work done by Michaela Diana in AirCAD very nicely has mapped out ischemic metabolites in the bowel of an ischemic intestinal model, and then is allowed to feed back software to the computers in order to make this really a simple real-time analysis. So I guess what we're looking for is a green light, red light system that will tell us it's safe to proceed, or there is concern about the anastomosis, and simply by doing different grading of the light returning back, you can assign different color codes to it. This is really, I suppose, in simplest terms, a bit like what a pulse oximeter does, which is a near-infrared technology converting colours back into a numerical readout. Or indeed, it's something like what a CT scan in describing different characteristics of different Hounsfield's units. So it might seem that all this is very straightforward, and I guess, you know, it's a matter of technology and individualization of patient care. And in Beaumont Hospital, we've been lucky in having a robot which can help us do these kind of operations. The problem is, though, is that although we have these capacities, it's maybe not very widespreadly distributed. And how we integrate these things back into clinical practice is a challenge. So laparoscopic colorectal surgery has probably the best evidence base of any laparoscopic procedure, and its trials far better than those that justify us doing liver resections for colonic metastasis. But yet it hasn't penetrated well into the general surgical community, and this has been an international problem. And the LAPCO program in England, of course, really had a dramatic effect on it. But what do you do in the absence of a multi-million-pound investment program that's driven by the government in order to ensure that clinicians take advantage of these kind of technologies? And of course, everyone knows these issues as barrier to uptake. But maybe these are sometimes just simple ways of dismissing a topic that we really don't want to engage with, because it's very difficult for any of us to really know what every part of every minute of every procedure costs. And sometimes it's just examples of superficial thinking that's preventing the implementation of techniques. One other issue is as we move towards industrialization and standardization and protocol-driven care is a danger that we risk specialization becoming actually commoditization, and that all this seems just a simple checklist of work to be doing. The balance, of course, we don't want to fail the patient on the table in front of us or the clinic in front of us, but we equally have to have a view on the patient who's coming next week, next month and next year. And it's important that we do really try to understand what is the barriers to implementation in an honest and truthful way, and not just deal with the superficial aspects of it. And an example of that, I think, is if people walk through the trade show, you might just watch yourself as to how long are you spending before you dismiss a technology. The average, I think, is about 16 seconds. Certainly less than the amount of time you pick a tie or your dinner menu from. In Ireland, we should be pretty well set up in order to integrate technology safely. We have a homogenous patient group. We have hospitals in close proximity, and we have demographics of surgeons that are very well aligned between each department. The problem is, though, that increasingly we're working in isolation from each other, partly because of things like centralization of care. And it is setting up institutions maybe to be a little more competitive than they need to be. And institutional over-loyalty is, I think, a bigger danger as lack of loyalty. The other issue we have is, as we're moving through the recession, is a dichotomy developing between younger surgeons appointed in the last 5 years versus those beforehand to it. And this is going to be increasingly difficult unless, as a profession, we work together in order to ensure things are going, that we remain united on it. Otherwise, there's a potential of a fracture, which I don't think you need to be Robert Smith to recognise. The role of the academic surgeon, I'm going to conclude here, Mr. President, I think really is going to become increasingly important, as the clinical director's job, certainly at this time in Ireland, is, I think, to break bad news about how things can't be done. But the role of the university surgeon or the academic surgeon, I think, really is to maintain a clear view that surgery is really a privilege for us to do, and it's an exciting opportunity to improve healthcare among the public. And we need to demonstrate better. This is why you pay your taxes. This isn't about that the public's money should be spent in a way that demonstrably makes them feel like they're getting good care. So rather than retreat into ivory towers, I think the university surgeon increasingly has to make sure these type of technologies get into widespread use, which is going to need quite some honest discussion among us as a profession in order to make sure the different generations, the different aspects can be included, that we don't have artificial barriers to implementation. So I'd like to thank the audience for their attention, and again the Association and the College for the invitation to present. Thank you.